Okay, guys, we're going to go ahead and get started, and I'm going to discuss a little bit about traction. Um, so, when you first come across traction, know that the main purposes are to maintain the correct alignment of a reduced fracture, and this is going to prevent nerve damage and dislocation. So, when you suspect somebody has a fracture, assess the skin color, temperature, movement, and sensation, and of course the pulses. And I think we discussed that a little bit in the last seminar as well. If they have just like a simple sprain, you might just have to ice it, wrap it, and keep it elevated just to keep that swelling down. But keep in mind that nobody has x-ray vision, and we discussed those fractures that sometimes are hidden until they actually do a bone scan to confirm it. So traction is a pull in one direction, but requires an equal pull in the opposite direction. So application of a pulling force to an injured or an injured body part, the counter pressure pulls opposite. So usually it's the person's body weight. It could be elevating the head of the bed, elevating the knee gauge. Can be by means of ropes, pulleys, and weights. If a person slides toward a pulling force, there will be a loss of traction. So if for some reason your patient starts to complain of pain, usually traction does not cause pain. So look and see if the weights are properly in position or aligned with the person in the bed. When somebody's in traction, they need to be lined up. They can't be off to the side, or the weights can't be touching the ground. If the pull is too great, the injury could be pulled apart too. So that's why it's imperative that the proper weight hold the bones together versus too much pull and separating, because you want to make sure that it heals real good. The two common types are skin traction and skeletal traction. So skin traction is short term, anywhere between 48 and 72 hours, where skeletal is going to be a little bit longer than that. So intermittent, according to time, means that it's going to be periodically removed. So that actually can be done in the home, or it can be done at the hospital, but a lot of times they do it at home. Continuous means there's a constant pull, and patients cannot be removed without injury occurring. So don't remove the pull or the traction when you're doing patient care. Make sure that you support that traction. Skin traction is temporary, usually no longer than 3 days, has skin contact by means of weights attached to boots, traction straps, tapes, slings, halters, etc. It helps keep the muscle spasms of the injured extremity down and decrease. Remember when I said if somebody has a fracture and it goes over and they bring the bone back in alignment, this soft tissue up here, it gets all bunched up and balled up, and the muscle actually gets aggravated. So that muscle is going to continue to occasionally twitch and stuff. That's a muscle spasm. So a lot of times they'll help by keeping the traction in place, but they'll also give them muscle relaxers as well. And that was when I was talking to you guys about not touching them with cold hands, because when you touch somebody with cold hands, automatically their muscles clench and grab. Okay, on the next page, you see figure A, which is Buck's traction, and you see figure B, which is Russell's traction. So in Buck's traction, you got to keep in mind that the pull is like a straight pull. Okay, it's pulling straight, and if you notice in the Russell's traction, there is a up and down, and there's a pillow. I mean, usually if we're in face-to-face, I'll say I'll have you guys look at the pictures and tell me what differences you see, and then we'll talk about them and stuff. Either way, you need to assess for pain in either or. The weights Make sure that the rope is in the pulleys, the weights are not on the ground. Now the person in Buck's traction, keep in mind he only has one, well, they both actually have only one bad leg, but the guy in Buck's traction, he has a trapeze. So we want him actually using that other leg to help us boost him up, because while he's boosting with that, we're going to be supporting the weighted pull of the traction. So let's see. Also, another thing, one thing that with Buck's traction, sometimes they have to be in it overnight. Like I had a woman who, she fractured her hip, and my mother-in-law fractured her hip, and she couldn't have surgery because she was on a blood thinner. So they wanted to wait until the blood thinner was going to be out of her system, or at least lower her bleed time. So they put them in traction like overnight or over the weekend. So Buck's traction can be unilateral or bilateral, and it's usually temporary for back injuries, hip fractures, like I said, arthritis. Could be intermittent for fractures. Manual traction is needed to be performed whenever the boot is removed. If the patient has any, like what I said, sudden or severe pain, especially after you move them, you got to check. And every time you reposition somebody who is in traction, you have to start the survey of the traction of the pull and everything. And it could be something as simple as putting them on a bedpan and taking them off the bedpan. Still, you have to go through the checklist, the traction checklist, and make sure that everything is in aligned. Now, our priority assessment for anybody in traction and is nerves, and we were talking about compartment syndrome the other day. So we want to make sure that there's no sensation loss and that there's not a complication. This could also be bed sores, because they are in bed, not moving. We're limited on how we reposition them. And something that when I usually do when we're face to face is I'll say, okay, what are the pressure points? What could possibly be the pressure points for people in this sort of traction? And then we would talk about how we could prevent those, and how to assess their back when they're on their back and they really can't be rolling around and stuff. So a lot of times what we'll do is, and I always say, take a flashlight with you, because if you don't take a flashlight with you, it's still kind of dark under there, even with your big overhead lights on and stuff, because you got to assess their shoulders, their back, their coccyx, their heel, their ears. I saw a decubitus on an ear once. Let's see, what else do I want to say? Make sure that the leg doesn't make sure that it's in good alignment and that it's not touching the foot of the bed or hanging, or the weights are hanging on the floor. The real difference between A and B, I have a little blue note here that says the sling is, I mean, they can put it up on a pillow when they're in Russell's traction. So usually they do that with the fracture of a femur or a tibia counter traction. They could elevate the foot of the bed as well. Then we move down to the pelvic traction. Pelvic traction may be used to alleviate low back pain, hip and leg pain, decrease muscle spasms. Counter traction is the Williams position. So the patient can actually, take themselves in and out of this one if they want to, and it's used to relieve low back pain. So 15 degrees, 20-degree elevation, the knees are 30 to 45 degrees. Head of the bed, this tilts the patient's pelvis down, so their lordotic curve, and allows pull to be applied to the straight lumbar column. All right. Cervical traction relieves muscle spasms and nerve compression. Counter traction is the elevated head of the bed and the person's body weight. Person can also take themselves in and out of this, and sometimes it's done at home. Keeping in mind, and this, I have a note here that Russell's is used in fractures of femurs or tibias. Counter traction is the elevated foot of the head of the bed, which I just read. But I also wanted to make sure that the cervical traction that I just discussed, that I mentioned, that this isn't for cervical fracture or spinal cord injuries, as you can imagine, because we want to make sure that we have a solid foundation where that head's not going to move anyway and cause damage. Okay, Bryant's is used for kids under 2 years of age for fractures of femur, tibia, and or fibula. It's also for congenital hip treatments. Counter traction is the child's torso. When we look at this, it's usually used less frequently because of the extremities. And look at how the baby is strapped up like that. And if you can think about how blood flows from head to toe. It's going to be real hard to get blood to flow up. So there's a possibility of pooling of blood at the hip area, possible tourniquet effect with the traction straps and the bandages because of the possible vasopression and vascular hip necrosis. So we really got to watch that. There is straight up and down. So then again, I would also pose this question if we were face to face. This baby is in a position, and it's in a position where that it could also have pressure ulcers. You know that pressure ulcers begin from the inside and they work themselves to the outside. So where would this baby's pressure ulcers most likely be? I say the shoulders and spine pressure areas. So we would want to assess those every couple hours and make sure that we do some kind of skin care or monitor so that the baby doesn't have any breakdowns or anything. In all my years of nursing, I have never seen this traction. So, okay, Dunlap's traction, upper limb traction for treatment of elbow fractures. I actually found a little information sheet on it. It says that it's used maintenance of reduction in supracondylar fractures of the humerus in children, allows swollen elbow to settle, contraindicated in open fractures and skin defects. It is one of those tractions that if they are put in it, they go to surgery with this. So you're going to take the whole bed and everything to surgery until they can fix it. Skeletal tractions usually in place longer than skin traction. It's a continuous traction, weights pulling on pins, wires, or tongs, which have been inserted in the bone, partial or completely. Skull for cervical traction, the Crutchfield or Gardner-Wells, the Halo. What do I have a note here? Oh, I found some information. The Halo ring is held in place with 4 pins in the skull and lower spine curves that are severe are used with, let me start over. I can't even read my own writing. It's held in place by 4 pins in the skull. It decreases spine curves that are severe, used with cervical instability or high thoracic deformity, which you can imagine, because they want to keep that stable. It's used to align bones and joints, used to treat a joint contraction or congenital hip dysplasia. Now, skeletal traction, you might have seen like hardware in hands, hardware in knees, ankles, external hardware. So there's pin care that has to go with that. And I looked something up on that too about pin care. This kind of traction is used for long-term pull that keeps the injured bones and joints aligned. It can be a weight anywhere between 4 and 45 pounds, but again, keep in mind, too much is not good. It'll pull it apart. The major disadvantage of this is the infection where the pins has been inserted and consequences of prolonged immobility, which are, because we are treating this person for a fracture and pain, could be constipation, could be bed sores, could be urinary tract infections, could be DVT. So we're going to put them on some kind of DVT prophylaxis. I don't know. But anyway, we'll watch their lab work, and primarily their ESR and C-reactive proteins, their white blood cell count, their hemoglobin, because they could have lost some blood. The Thomas split with Pearson attachment is used in femoral fractures. Thomas, 2 rods at either side of the upper limb and padded half ring at proximal end. Pearson cradle supports the lower limb off the bed. So I've seen this used in athletes, some people who've been in car accidents. It's greater risk it's the greatest risk other than infection with this one is pressure ulcers, as you can imagine. So, we never remove the traction, and you're like, well, how do they change the bed? How would you, in a face-to-face, I'd ask you, how would you change a bed? In CNA class, you learn to change a bed, an occupied bed. How would you do that safely? Well, now you have to also do it with someone in traction. What you do in this case is you're going to work from the bottom up. And during this time, you're also going to do your assessment, your skin assessment. So you're going to look at all the pressure areas. So when we're face-to-face, I usually say, where are the pressure areas here? Where do you think they are? Well, of course, the back, the sacral area. So you need to assess those. The patient can actually use the trapeze, bending and pushing and using that unaffected leg, because as I mentioned in our seminar last week, was that some people want to stiffly move themselves when they really don't have 2 broken legs, they have 1. So we got to keep that other leg working so that it doesn't get weak. All right. Assessment of traction. Let's go through that. Let's go through this little checklist here. Okay, each shift, the following areas are to be assessed. Desired line of pull in relationship of distal fragment to proximal fragment. And be sure that anytime you move your patient, again, I cannot stress enough, go through the traction checklist and make sure everything is checked. Check position of the frames, the splints, the ropes. They should run over the midline of the pulley, away from the pulleys and without interference. Knots should be tied securely, and no fraying. We usually tape the knots and tie them really tight. So weights are of the correct amount of pounds and hanging freely. Never remove if patient is in continuous traction. We do these checks every 2 hours, or follow your policy if it's more than that. Bed position, head or foot is elevated according to the desired amount of pull and counter traction. If you need to lock out that foot of the bed and the head of the bed so that the patient doesn't move themselves, which they could very innocently do because they want to be comfortable, but they need to turn their light on, and we need to help them do that. Patient is in body correct alignment when their shoulders, hips, and knees, legs, they all align. It's important when moving the patient that limit turning of patients, wait until they're healed a little bit more. Log roll the patient if they're in skill tongs only. And then I would ask you how you would log roll a patient, okay? And the main thing is to have enough people to do it safely, and the person who is in charge of counting and directing is the person who is at the head. But that's what I'd ask you to tell me in a face-to-face. So roll to affected side if the patient is in the Thomas Pearson traction. Roll to the unaffected side if patient is in Buck's traction. Note any neurovascular changes, especially distal to the injured part. Alterations in sensation, numbness, tingling, pain. Check the web spaces between the digits. I don't know if I know I gave one of my groups the paper. I'm not sure if I gave the other group the paper. And I had it like 5 seconds ago. Let me see where it's at. There was a handout that one of the students had from, I think it was last year's course, that shows, oh, here it is, that shows the webbing and stuff. Okay. I don't have an electronic of it, but I can show it to you. If you can see it. Hold that thought. Well, I can't figure it out, but I was going to try to scan that in, but it is in your textbook. I don't know what page though. Okay, let's see. Alterations in sensation, numbness, tingling, pain. Check the web spaces between the digits. Alteration in motor ability. This is where you would do those 5 Ps that we talked about, the pain, pulse, paresthesia, paralysis, and pallor. Does patient have active movement in the distal extremity? You know, is there edema? If a patient is in Thomas Pearson traction, treatment, then make him dorsiflex and stretch plus do quad exercises. Pulses in comparison to uninvolved limb, popliteal space, pedal and capillary refill should be checked, color, temperature, skin, and nail beds. Check bony areas for any breakdown, pressure on the coccyx, the shoulders that I was talking about. Teach patient to lift his buttocks off the bed every 1 to 2 hours. No wrinkles in the sheets and good skin care. We learned that in CNA. Pillows are not considered a part of traction equipment and can sometimes undermine the effectiveness of the traction. So patients should not be in any pain due to the traction. And as we discussed, if they are, start with and look at the whole system and see what's going on. Skin traction would be tape to the skin, ACE wraps. Assess the bandages correctly applied, that they're not too loose or too tight. If necessary, remove the limb. You will need assistance of others to maintain that traction, so get a couple people to help you. Skin needs to be assessed every 1 to 3 days and cleaned every 2 hours with traction. I check minimally every 8 hours. Anything like I don't know. It's to me, I'm thinking I'm checking it every shift. Skeletal traction, pin sites frequently for signs of bleeding or infection. The pin screws can be certain that the pin screws are tight in a metal clamp that attaches traction apparatus to the pin. Skin at pin sites, clean those daily, not with betadine because that'll cause metal changes. And one time we did that like a lot and stuff, and then we noticed that it was causing an issue with the pins. Keep the heels off the bed and ischial tuberosities. Okay. Prevent complications while in traction, hypostatic pneumonia and or atelectasis. Okay, so if we were face to face, I would say, what nursing interventions would you do to prevent this? And of course, it'd be like the incentive spirometer. And if you have kids, you can play games with them. Like I think during our PEDS, like when we did the PEDS assessment, and we were talking about this in the pediatric portion of OB for post-ops, you would have them blow a cotton ball, have them like pretend to blow out birthday candles. Also constipation. We don't wait for them to get constipated. We address constipation from day one. Urinary tract and kidney stones, it's because the increase of calcium that gets gets released after the fracture. Plus they're immobile, so that non-weight bearing. Muscle atrophy, this is where we can exercise the other limbs. Wound infection, self-care deficit, sensory deprivation. What I mean by that is, like, think about a kid. We had a 5-year-old who actually within about 3 weeks of each other, they came in with femur fractures, and that was when trampolines were really popular. And oh my gosh, this kid was amazing, but he needed to he needed schooling and school activities, and he needed friends and, you know, visitors, and just, he really needed to be entertained. So we had to make arrangements, and a teacher would come and work with him, usually in the afternoon. Depression, those are your adolescents. Sometimes they get a little depressed because you know, they're missing out on things. Skin breakdown, so we're going to encourage the patient to kind of sort of move themselves. All right, so clinical application. 78-year-old Bessie slipped and fell on the ice and is admitted to the hospital. She has a fractured left femur neck. She is in Buck's traction with 5-pound weight applied. She states she needed to urinate. So describe how the nurse assists her to use a fracture bedpan. We're going to roll her to the unaffected side. So we'll roll her to her right. And I also like powder the hand rim a little bit, just because some of these little old ladies, it sticks to their skin, and I don't like to spill urine in the bed, and I don't like to wear urine. So I'll put a little powder on the pan, and that's all we'll do. Bessie has a portable x-ray of her left hip. During the procedure, the traction lines catch on the bed frame. So what does a nurse do when checking Bessie after the x-ray is complete? Again, the checklist. And that includes your neuro assessment, check alignment, position. You're going to reassess and document. Please, please, please don't forget to document that, because if it's not documented, it wasn't done. And then if there's an issue, it's going to look like you didn't do the assessment to check. Bessie is scheduled for an ORAF of her hip fracture. Upon return to her room from the PACU, a Jackson Pratt device is in place. So what are the nurse's responsibilities relative to this drain? Well, as with anything, it is check the drainage, check the dressing, look at the insertion site, properly empty it. Is there suction? Is there enough suction? Is the bulb compressed? Let's see, post-op vitals, check the Jackson Pratt, and you might have to remove it too, like when it's time. So describe the assessment of the nurse performs relative to this type of drain. Well, the incision site for infection, dressing, and compressed functioning. All right. Ooh, here's another document. I wish I knew how to scan. Okay, this shows about going up and down stairs. Okay, let me see if I can show it to you. Notice how the leg going, wait, which finger am I on here? Going up the stairs with the good leg, so all good girls go to heaven. So up, and then going down, you lead with the bad over here. So crutches down and bad leg to protect. Leave the crutches down, bring the good leg up. The crutches are always protecting the bad. Okay, if you can see that. All right, so Holly is a 16-year-old female who fell while skiing and comes to the walk-in clinic where you are a nurse. Medical evaluation indicates that she has a right knee injury, most likely a severe ligament tear. Holly is given a set of adjustable crutches and instructed to avoid weight bearing on the right leg until seen by the orthopedic surgeon. So how should the crutches be fitted for this patient? Well, we don't want them putting the crutches in their armpits, because if they're in their armpits, they could have some nerve damage, okay? And so we want them to be 1.5 to 2 inches below the armpits with the shoulders relaxed, okay? The hands are on the grips, the elbows are slightly bent, and encourage them not to fully extend their elbow you want them to fully extend their elbow when they're taking a step, but you don't want them putting pressure on their armpits. What else? Oh, good shoes. Okay. What I thought was really funny was, and I don't know if you guys remember this, but Kim Kardashian, or one of the Kardashian, I don't know, she was on crutches, taking a photo in front of like I don't know, some kind of award sign show or whatever, and she had her leg in a boot and she had on a 5-inch pump-ish kind of thing, and I thought to myself, I just want to watch her walk off, and stuff, or how exactly are they going to do that? It was kind of funny because she was styling, but that's not safe, and I'm sure that's probably what not included in her education. So the what crutch walking gait should be the best to ensure that she is non-weight bearing on her right leg, and why? We would do the 3-point because this keeps that injured leg off the floor. So you're going to start and end in like a tripod position. So it's lift the good leg, swing body. You're going to swing body up to the crutches. Okay. So the swing to is swing the body to the crutches. The swing through is when the body goes through the crutches about 12 inches in front of the crutches. So the swing to is to the crutches, swing through is about 12 inches through the crutches. Describe how to teach Holly to go up and down stairs safely. It was kind of on that, what I showed you on that paper. Sit and rise from a chair. So make sure it's a stable chair, and you're just going to stand with the back of her legs touching the chair. Place the crutches in one hand, hold onto the side of the chair, and then she can lower herself down. Well, she's going to do that same thing to get up from the chair. Always make sure that if you take their crutches, you don't take them too far away from them. So what other safety measures should the patient know in using crutches? Never look down, look straight ahead. Never use if you're dizzy. Let's see, rubber tips, don't use the armpits, check the proper height, watch electrical cords, no rugs, watch for small objects, avoid revolving doors like that. I think I got these out of the textbook, and stuff, but avoid revolving doors. Hold closing doors with one crutch, arrange house so that it's handy, a backpack, apron or fanny pack, something like that so that you can be hands-free. David is 32-year-old male with advanced HIV who has severely sprained his ankle. So what type of treatment for David's injury do you anticipate will be ordered? Well, the people with HIV have very low bone density, so we need to be very, very careful with the crutches and make sure that there's really no fracture here. So we need to assess him, right away. We'll probably he'll probably experience some fatigue. He might have some muscle spasms. So we might put him on maybe some NSAIDs. And then know your abbreviations for the different weight bearings, like NWB, no weight bearing, TDWB, touchdown weight bearing, so foot may rest lightly on the floor but no weight. Partial weight bearing is some weight, and weight bearing is tolerated, WBAT. Sometimes you'll see those on the charts, but probably not so much anymore because of the push to get away from the abbreviations now with our electronic charting. He is given a set of crutches to use until he sees an orthopedic physician. What crutch training gait would be most suitable for his situation and why? Again, I would do the 3-point gait, and I would also watch his progress and then advance him as needed. BJ is an elderly independent neighbor who has osteoporosis and arthritis. She has lately had a lot of pain in her left hip and has been unsteady on her feet. She decided to use a cane when it got difficult to get her groceries at the grocery store. She told her doctor that she was going to use a cane because it will help make her a little sturdier. What would you teach her about using the cane? Well, keep the floors clear, good shoes, Stand and then get your weight bearing. The 4-point cane is probably the more stable. If she has left hip pain, make sure she uses it on her right side related to that weight distribution. And it should be 6 inches to the side and 6 inches in front at hip level, you know, so that her elbow has a slight bend to it. Madeline, age 85, has significant effects of osteoarthritis and has begun using a walker to assist with ambulation. As the home health nurse, you would want to evaluate the safety of the assistive device. So what would the nurse include in the safety evaluation of the walker? Well, don't carry it, use it. Look up, don't watch yourself walk. Rubber caps or tennis balls. Make sure it's the right height. Make sure you got good lighting. Don't be hooking a basket or baggie or whatever on the front of it, because that in itself will create a extra weight on the front and might make it tippy. How should Madeline be using the walker when ambulating? Push or lift the walker a few inches in front of her. Make sure all 4 tips are touching the ground. Step with weaker leg first. Okay, compare the advantages and disadvantages of plaster cast versus fiberglass cast. Well, your plaster cast advantages are its increased moldability, conformability. It's easier to apply, it's cheaper, there's more support for the bad breaks, and it's used for bones not in alignment. The advantages of a fiberglass cast is it sets quickly, they're lightweight, less bulky, strong, water resistant, can bear weight in within minutes, fewer skin issues, and when the bone is not, and these are used when the bone is not in alignment. So the disadvantages of a plaster cast are not waterproof, heavy, bulky, they can cause skin breaks, and they're kind of messy. Disadvantages of fiberglass cast, of course, is the cost, decreased moldability, potential for skin irritation, and sticky on application. So all right. What am I doing here? Oh, cast care. I found a website that talks about cast care. So when you're assisting putting on somebody's cast, make sure that you use the palms of your hands and not your fingertips, because if you do, you might not see the indentations on the outside of the cast, but they might see them on the inside of the cast, or by the leg, where the leg is, and there might be some rub and wear marks. Use a cool dryer to blow down the cast. If they itch, they can also take Benadryl. All right. PD is a 20-year-old patient with fractures of the right tibia and fibula. He has a long leg fiberglass cast that was applied, and now he is going home. List the 5 most important patient teaching measures to be given to the patient before he leaves. Well, if any tingling occurs, he needs to call the doctor. Don't stick anything down that cast. Check sensation, circulation for drainage and safety. If PD gets the cast wet, what measures should he take to dry it? Well, a dry, clean cloth, of course. PD comes back to the ER 1 week later and states the itching is driving me crazy. Do something. He is carrying a kitchen table knife. Oh my God, that is too funny, because I actually cut a cast off and found a butter knife in somebody's cast. To scratch under his cast. What does the nurse tell PD about using the knife to scratch under the cast? Stop it. You may puncture the skin and cause infection, and it's gonna not be good when the person taking your cast off finds it in there because you dropped it in there. What other measures may be used to assist PD in coping with the itching? Keep cool, well-sealed ice bag over the itchy skin, change position, hair dryer to cool air under, and he can also take some meds. 16-year-old Amy has come into the clinic to have a long arm cast removed. She's extremely anxious and worried about getting it off because and also concerned about her arm is going to look like. What can you do for Amy? What teaching would you provide? Well, first of all, emotional support. Poor Amy. Explain that this is going to be normal and that she may have atrophy, but it will get better the more she starts to use it and stuff. So she kind of sort of needs to maybe not push herself too much, but kind of watch a little bit there. All right, the boys. Let's talk about our boys. Brandon's an active 5-year-old who lives with his parents and 2 older siblings. He's very social and loves playing with his friends near their home. Both of his parents work. So during the school year, he attends preschool. In the summer, his 14-year-old sister watches him while their parents are at work. He enjoys playing with his cars and action figures and running and climbing outdoors. His father built the children a play area behind their home where Brandon does most of his outdoor activities. While their sister is in the house talking on the phone, that was before the day of the cell phone, evidently. Brandon does, where's she at? Well, she's in the house on the phone, not paying attention to the kids. All right. So Brandon, his 8-year-old brother Greg are playing in the jungle gym and decided to climb to the top and play even though their parents have instructed them not to do this. Greg climbs up first, encouraging Brandon to follow. Greg loses his grip and begins to fall. As he is falling, he knocks Brandon to the ground and lands on Brandon. Brandon is on the ground holding his left leg and left arm. Greg is lying next to him holding his right leg. The sister helps both Brandon and Greg into the house and lies them on the couch. She calls the mom for help. On admission, the nurse assesses Brandon and Greg. The nurse visually notes Brandon's left arm and leg appear deformed. He is crying, saying his arm and leg hurt. Greg's knee is bruised and swollen with no breaks in the skin. Both boys are alert and oriented. Vitals are stable. Which child requires priority care and why? Well, Brandon, of course, because he has obvious deformities and suspected fractures. So, first of all, you're going to discuss the significance of Brandon's manifestation because this was a trauma. So what was the mechanism of injury? This could cause other complications such as like a fat embolism. It could he could get compartment syndrome. He's in severe pain. So we're going to be doing all kinds of assessment. Plus, there could be like some hidden injuries as well, especially in that kind of trauma. So, discuss the impact of Brandon and Greg's level of growth and development had on this situation. So, well, why did this happen? Because Brandon's a follower, okay, and that's typical at this age. So, interference with growth and could be if there's a fracture in the growth plate of any sort or if it's involved. And then some kids need kind of lengthening and shortening procedures later in life. So we'll have to make sure that we didn't hit a growth plate. At the scene of the accident, what are the most important nursing interventions? Well, splint the injury to prevent further trauma and pain. Splint up below and above and below the joint of the suspected fracture. Provide comfort and support. I'm going to C-spine him probably because he did have a fall. And then watch my ABCs, airway, breathing, circulation, and immobilize, without realigning it. We discussed that. What other assessment data is necessary for the nurse needing in order to prepare a plan of care for the kids? Well, first of all, I need to know when they go home, what kind of support are they going to have? Are the parents working? How's their bathroom set up? Where's their bedrooms? A past medical history. The last time they ate would be good because I'm going to possibly send them to surgery. Any past surgeries, are the immunizations up to date? Neuros, meds, allergies. Also, at this age, you want to know what their habits and their likes and dislikes are because you kind of you're going to have them for a little bit, so you might need to entertain them. So what are the priorities of care for Brandon? Well, first of all, it's make sure secure an alignment of bones, pain control. He's also going to have cast care, teaching, crutch walking. Will mom be able to care for Brandon, with a fractured left leg and arm and the hidden injuries that I mentioned earlier? Discuss the potential complication of Brandon's fractures are not properly cared for at the scene of the accident as a result of lack of care. Well, immobilize the joint above and beyond to prevent movement and muscle tension and further dislocation, neurovascular, or even spinal cord injury. So the sister carries the kids in the house, lays them on the couch, and calls his mom or calls her mom. So that probably wasn't the best thing to do, but you need to interview them to be sure of this and make sure you document it so that the mechanism of injury can be identified as potentially the transfer of the child into the house. The emergency department healthcare provider is able to reduce Brandon's fracture of the arm and leg and place the extremity in a fiberglass cast. Discuss the rationale for applying this type of cast and identify the priority nursing intervention following cast application. Well, neuro teaching and skincare, of course. Fiberglass casts are lighter. We can elevate them on the pillow for the first 24 hours. We're going to observe them moving their toes and fingers and ice it. No rough housing. They're boys, and they've already got each other in a difficult spot here. Teach them the signs and symptoms of infection. Keep the cast dry. Make sure they do their follow-up appointments. Discuss the teaching priorities for both Brandon and his mother before discharge. Well, all the above, right? Pain management, adequate pain relief. Don't be sticking anything down it. So I think we answered that in actually 8. In 8 weeks, Brandon's mother takes him to the orthopedic clinic to have his cast removed. Brandon's very quiet and cries as the nurse approaches him. Brandon is clinging to his mom. Discuss your impression of Brandon's behavior and how the nurse could respond to this. Well, the nurse can actually reassure him, can speak in a quiet voice, calmly explain, because he's fearful of the unknown. And kids, as we discussed in the pediatric unit in 2202, kids can regress, and that's normal. So list and priority interventions for a school-age child hospitalized with bilateral leg skeletal traction following an accident. Be sure to include age-appropriate activities. Identify interventions that may be delegated to a nursing assistant. All right, well, there's board games, there's card games, there's routines, body position, neurochecks, nutrition, neurochecks, temperature, edema of the lower extremities. I do those every 4 hours. I'm taking this actually off of the checklist from the hospital. Move their toes, sensation, maintain traction alignment, report numbness or tingling, pain or cold, check pins every 8 hours for redness, nutrition, possible antibiotics, their elimination, range of motion. What safety and development issues would you include in teaching a plan for a 7-month-old with a broken femur due to a fall down the stairs? Well, first of all, you would consider abuse, but not always, but always keep that in the back of your mind. Femur fractures cannot be casted immediately because strong tendon spasms usually cause poor alignment and overriding of the femur segment. So alignment is initiated first by treatment, Bryant's traction, sometimes for the first 7 to 14 days, and then they'll cast them in 3 to 4 weeks. So discuss with mom and dad or caregiver the safety of safety gates, document the injury, make sure that you separate anybody who comes in and interview them, to make sure that the story is aligned and actually makes sense. All right, so let's do our case studies here. I'm not going to read the scenario. I'm just going to read the question and then the answer. Okay. List at least 4 risk factors for hip fractures. Well, you've got age, decreased estrogen, without estrogen replacement, therapy when women are in menopause, smoking, lack of exercise, corticosteroid therapy, anti-metabolic therapy, rheumatoid arthritis, long-term use of proton pump inhibitors for GERD, personal or family history of fractures, and osteoporosis. Place a star asterisk next to each of the responses in question 1 that represent SP's risk factors. So really all of them apply except for personal and family history of fractures and osteoporosis. So, all right. Why is SP receiving Lovenox and Coumadin? Well, orthopedic patients fall into that high-risk category of venous thromboembolism, deep vein thrombosis, and pulmonary emboli. So the Lovenox is a low molecular weight heparin and has an effect on clotting factors, but acts higher in the clotting cascade than heparin. So it binds less to nonspecific plasma proteins and helps maintain that constant level of anticoagulation. Lovenox is used in combination with Coumadin until the therapeutic level of the Coumadin can be reached, because this can actually take up to 72 to 96 hours. So Lovenox is used early and post-op period to prevent the thrombosis, and then discontinued after at least maybe like 5 days, as long as the INR is anywhere between 2 and 3. Coumadin therapy continues for about 5 to 6 weeks after surgery. Some docs recommend it for about 3 months. It's the physician's call, really. So why is the antibiotic to be stopped before anesthesia end time? Well, according to the Centers for Medicare and Medicaid Services, antibiotics must be stopped 24 hours after anesthesia end time. Studies have shown, again, evidence-based practice, that administration of antibiotics prophylaxis for more than a few hours after the incision is closed does not offer any additional benefit to the patient. Instead, a prolonged administration may increase the development of pathogens that are resistant to antibiotics and increase the patient's risk for developing C. diff. SP had an arthroplasty for each of the characteristics below. Mark A for arthroplasty and O for open reduction and internal fixation of the hip. So also known as a total hip replacement is A. Metal pins, screws, rods, plates are used to immobilize the fracture. Of course, that's O. And replacement of the entire hip joint with a prosthetic artificial joint system is A. SP receives reinfused blood as an intraoperative blood salvage. Which statement about this procedure are true? Select all that apply. B and E are the correct. List 4 critical potential post-op problems for SP. Oh my gosh. I mean, that's any post-op, right? Fat embolism, bleeding issue, atelectasis, pneumonia, dislocation of the hip joint, infection, pressure ulcer, unrelieved pain. Anything that goes along with post-op. How will you monitor for excessive post-op blood loss? Well, look at the dressing, the amount, monitor the vital signs, check the hemoglobin and hematocrit, send stools to the lab if there's any question that they might be passing blood, especially if they're receiving Lovenox and Coumadin. Unusual swelling, discoloration at the surgical site, and monitor level of consciousness for restlessness and pain. Usually if somebody is having some oxygen issues where that they're having difficulty breathing, they tend to get a little restless. So that could be a PE, it could be, they could be having a PE or fat embolism. Now, something that I always like to add is when somebody has a fat embolism, they'll get that petechial rash, whereas people with a PE won't have that petechial rash. So just a little difference in those. And I'm not sure, but I think we talked about that. I think we talked about that before. According to the posterior surgical approach, there are 2 main goals for maintaining proper alignment of SP's operative leg. What are they and how are they achieved? Well, extremes of internal rotation must be avoided. Abduction of the hip should be maintained by using pillows or an abduction pillow splint between SP's legs. Pillows are also placed bilaterally under the calves. It is important to prevent that adduction of the hip. Extreme flexion of the hip is avoided by elevating the head of the bed no more than 45 degrees on the first post-op night until after PT comes in and evaluates. And the head of bed can be elevated up to like 60 degrees after the patient gets out of bed the next morning. Post-op wound infection is a concern. Describe what you would do to monitor her for infection. Again, vital signs every 4 hours, warmth, temperature of the skin, smell, sight, CBC with differential, the SED rate that we discussed, again, level of consciousness. Taking SP's RA into consideration, what is the reason for PT-OT consult? Well, PT will teach the patient active range of motion on the non-surgical joints to prevent stiffness and pain. The therapist can also teach the patient about proper procedure for ambulation, including like transfers to and from a chair. And PT will also prescribe the walking aid that they think would best fit that patient's needs. Now, OT would teach them independence and activities of daily living. So, as well as the assistive devices, and also like energy conservation and safety awareness. So OT works real close with PT and stuff to come up with what's best. Sometimes in the bounce backs and stuff like that, I've heard that they do a home visit so they can go in and check the safety of the patient's home. What predisposing factors identified in SP's medical history increase her risk for respiratory complication? Well, her smoking, of course, and her GERD, because she could be at higher risk for like an aspiration pneumonia. What predisposing factor identified in SP's medical history makes her at risk for infection, bleeding, and anemia? Well, she's taken methotrexate, number one, which could cause thrombocytopenia, leukopenia, or even anemia. Chronic immunosuppressions might result also from the prednisone therapy. Briefly discuss SP's nutritional needs, why she's receiving an iron supplement. Well, elderly women might need only between like 1,400 and 1,600 calories per day to keep from gaining weight, but special emphasis needs to be placed on the diet: high protein, calcium, antioxidants, vitamin C, zinc. She's receiving the iron supplement because of the blood loss from the surgery. We really want her to get it from her diet and stuff, so we might put her on a nutritional therapy consult with the dietitian, just so they can touch base it with her and her family to see what would be best. What factors need to be taken into consideration by the patient, family, and case manager when choosing a rehab facility? Well, if it's not a surprise, shopping around, I mean, not a surprise surgery, what I mean is like if it's planned, like a hip replacement or knee replacement, they can shop around, they can look, how close is it, location, of course, cost can be huge, and what kind of amenities do they have, what kind of go tour the rehab facility, ask about the food service, ask questions, and stuff. And also look on the internet and see what they have for patient ratings and patient care. All right, so we'll do our fractured hip complication one. Okay. So I'm not going to read the scenario again. So what will you do? Well, of course, you're going to stay with them, call the front desk, and have a rapid response team called and bring the code cart to the bedside. Raise the head of the bed, high Fowlers, get him on some O2 between 3 and 6 liters. Monitor his O2 sat. Keep him calm, because, if they get too excited, they start burning up their O2 that they got in their reserve. Take their vital signs, rapidly assess their heart, lungs, and neurological status. Look at his upper extremity. Observe upper extremity cyanosis, and when the code card arrives, place him on the cardiac monitor if he's not already on telemetry, because his condition might deteriorate very rapidly. So you want to get that solid baseline. You check his vitals, and his blood pressure is 98/60, his pulse is 20, his respiratory rate is 24. You note he is restless and slightly confused. His O2 is 86%, so you start him on 6 liters nasal cannula. You identify faint crackles in the posterior bilateral basis. Heart monitor on lead 2 shows a nonspecific T wave change. Yay. Using SBAR, what information based on the findings would you provide to the physician? Well, first you identify yourself, then you explain that MM is complaining of right-sided chest pain and is restless. For background, you state that MM is post-op day 2 after an ORAF of fractured left femur. Give him the current vitals and details of the respiratory status, including the lung sound, skin color, level of consciousness, and any assessment items that have been changed and the time period of those changes. Let doc also know that you started him on O2 at 6 liters per nasal cannula and because of his O2 sat being 86%, and that the ECG shows a nonspecific T wave change and tachycardia. The assessment of the situation is that MM is experiencing an embolism. Either fat or pulmonary. You would anticipate some diagnostic testing, some anticoagulation therapy, respiratory support, and probably a trip to ICU. The physician orders that the patient be transferred to intensive care and undergo blood coagulation studies, ABGs on room air, continuous pulse ox, stat, chest x-ray, stat 12 lead, ECG. So what information will the physician gain from these? Well, the blood coagulation study is going to tell us whether he's met the baseline anticoagulation therapy goal. His ABGs, even though the O2 sat says 86%, your ABGs could still be even lower than that. Because he's trying to compensate. So the ABGs is going to tell us the for sure oxygen status. The pulse ox is to determine whether there's an increase or decrease with the use of O2 and if the O2 is effective or if we need to, titrate. Chest x-ray is any fluid in the lungs, rule out pneumonia, rule out lung collapse, and pneumothorax. ECG determined rate, rhythm, ST wave changes indicating ischemia, right ventricular strain. Why would the physician order ABGs on room air opposed to with supplemental O2? Because you need to observe his basic pulmonary status. This will help you determine the need for a CT of the lung or even further testing for PE. So they give you the progress. So what are your interpretation of the ABGs, and what do you think physician will order next and why? Well, you can look at the pH, and the ABGs are showing that he's in acute respiratory alkalosis with hypoxemia. So he's going to order a CT and evaluate for a pulmonary embolism. And this is now the most frequently used test to determine for PE. If the patient cannot have the contrast medium, then he'll probably order a VQ scan. If the scan shows a probable PE, a heparin infusion will be initiated, so he'll be put on a heparin drip. If the patient can't tolerate the ventilation portion of the VQ scan, the doc will probably order a pulmonary arteriogram. A D-dimer test, they do a D-dimer test. Might also be ordered, and patient with a small pulmonary emboli might have just a positive or have a normal D-dimer result. So the chest x-ray image shows a small right infiltrate. The physician suspects an embolism, either fat or pulmonary, and orders a stat spiral CT of the lungs. Interpretation of the results reads strongly suggestive of a PE. So what are the most likely sources of the embolism? Well, a DVT from immobility that transferred, or a fat embolism from a femoral fracture. So each of the characteristics listed in the following, note whether there are characteristics of a fat embolism. So F would be fat embolism, and BC would be blood clot, and B would be both. So answers A, B, D, E, and F are both, and C is the fat embolism, which I mentioned earlier. Before the latest PT-INR results are back, the physician orders a heparin bolus of 5,000 units IV followed by an infusion of 1,200 units per hour. The lab calls with the critical value. The APTT is 120 seconds. Based on the result, what action will you take? Well, physician should be notified, the infusion should be stopped or reduced, and a follow-up APTT performed. The APTT should be between 1.5 to 2.5 higher than the control values. Monitor for signs of bleeding. Might send a stool sample to the lab if you have one, or if you can get one, and also watch them very closely for DIC because this complication is pretty good possibility. The physician is considering administering an antidote to the heparin. So which generic drug is considered the antidote to heparin therapy? C. Protamine sulfate is the antidote to heparin. Vitamin K is the antidote to Coumadin. So don't get those two mixed up. All right. The next day, the physician order reads Coumadin 2.5 milligrams PO, PT, INR in the AM, DC heparin. So what's wrong with these orders? It is going to take at least 3 days for the Coumadin to reach therapeutic level, so the gold standard for VTE prophylaxis is to continue and overlap that treatment, as we discussed earlier. Some thrombolytics, such as Activase, have been beneficial in the treatment of PE. Would MM be a candidate for treatment with a thrombolytic? Why or why not? Well, no, he wouldn't, because MM has had surgery within the past 10 days, placing him at risk for hemorrhage with the thrombolytics that were used. List 3 priority problems related to the care of MM in his current situation. PE and VQ's mismatch contributing to the reduced oxygen, carbon dioxide gas exchange. Hypoxemia and pain, they contribute to the breathing pattern that is ineffective. Hemorrhage secondary to anticoagulation therapy. Surgery, immobility, that's also less effective and can also increase his risk for infection. Several days later, you hear MM asking his son to bring a decent razor because he is tired of having beard stubble. How would you address this issue? Well, first of all, you got to remind him that he can bleed because he's on a blood thinner, and teach him about the Coumadin therapy and safety, and that a electric shaver is a little bit safer, a lot safer than a razor. Before MM goes home, you provide education about warfarin therapy. You inform him that he will be on medication for several months to prevent another occurrence of VTE. Which of these statements will be included in the teaching? Select all that apply. The answers are A, B, D, and E. All right, guys, that's it. I'm sorry, I tried to talk fast. I wanted to get you done. All right, see you next week.